Thank you for joining Cancer Support Community Atlanta for this program. Please visit our website, cscatlanta.org, for a complete list of live and recorded events. If this is your first time participating, we invite you to complete a new attendee form to stay connected to all future programs.
Welcome everyone. Again, this is Emily Brown, the Program Director at Cancer Support Community Atlanta. Thank you for joining us today on this program on genetics and breast cancer, led by Jazmine Vaz-Baker, a genetic counselor with Northside Hospital Cancer Institute. Just a little information for you to get started. You are going to be muted throughout the program, but we do invite you to ask any questions that you have in the chat box at the bottom of your screen. Jasmine will be happy to answer any questions at the end of the program. And just to do a quick introduction, Jazmine Vaz-Baker is a licensed genetic counselor. She was born in Florida and attended Florida State University, where she majored in psychology and biology. Following undergrad, she worked for 2 years as a substitute teacher and volunteered at a women's shelter. In 2019, she attended the University of Cincinnati's genetic counseling program, where she received a master's degree in genetic counseling. And at this past spring, she is now happy to be calling Atlanta home, and as a part of the Northside Hospital Cancer Institute genetic counseling team, she enjoys helping patients navigate through a genetic testing process. So thank you so much, Jasmine. I will let you take it from here.
Okay, great. Thank you, Emily, for that introduction. And yeah, very excited to be giving these talks. I like having kind of these community education opportunities to talk about genetic counseling, which is something that I love and always very excited to share about. So yeah, I'm one of the genetic counselors here at Northside Hospital, and we'll just kind of jump right into the presentation, so we'll have time for questions at the end. Are you guys seeing in advance?
I still see it on the main screen, or the first slide.
Okay, I'll just use these buttons down here at the bottom. Okay, so I usually like to start off with kind of using this book or recipe analogy. And when I'm in a session counseling patients, whether that's in person or over the phone or video, I really love this analogy. I don't recall exactly when I came across it, but I still use it today because I think it just kind of makes it a little bit easier to understand. So our genes, or all of our genes in our DNA, is essentially our body's instruction manual. It tells our bodies how to grow, how to develop, how tall we're going to be, how big we're going to be, our eye color, our hair type, our skin tone. Everything about us is contained in our DNA, our body's instruction manual. Another way to think of it is like a recipe book for who you are. And the chapters of our book would be likened to chromosomes, which are found inside of the cell. So that's this blue circle here underneath the book. These chromosomes are located in the nucleus, and that's kind of likened to the chapters of the book. All humans have 46 chromosomes. There are some cases where humans might have a bit more, and that's kind of a separate part of genetics, but typically 46 chromosomes, 23 pairs. So 23 of the chromosomes come from your mother, 23 come from your father. And inside chapters of any book are sentences and words and paragraphs, and that's likened to our genes. So that kind of brings me to that analogy. Our genes are these codes, these just long series of letters that contain this information about who we're going to be. So imagine if you started to delete sentences, out of this book, or duplicate sentences that shouldn't be duplicated, or switch sentences around. It's going to change this story. Whatever this story or instruction book or recipe book is about, it's going to change if you start to take away some of those sentences or those genes. Another analogy I like to use is thinking about baking your favorite cake or anything that you like to bake. If you leave out the part of the recipe instructions that say to add flour and you proceed to, bake your cake, you might get something at the end. Will it be a cake? Maybe not. Will it taste good? More importantly, maybe not. And the similar thing is with our genes. So you start messing around with things, taking things out, adding things where it shouldn't be, and it's going to change who you are. And sometimes that can increase your risk for cancer or other diseases. So that brings us to, types of cancer. There's hereditary cancer, and then there's sporadic cancer. And this is also something that if you, go to see a genetic counselor or have a genetic counseling session, specifically like in the cancer setting, that will be touched on. So most cases of cancer is sporadic. So by sporadic means that mutations or changes, or you can think of them as spelling errors, keeping with that book analogy. Most cases of cancer are sporadic, 70 to 80%. These changes, these mutations arise at random, isn't anything, that you did or didn't do. They kind of, just appear over time. So that's most cases of cancer. About 15 to 20% of cancers are what we call familial cancer. So that's when we might see cancers clustering in a family within, a couple of first and second degree relatives. So this might be, children and their parents having a similar type of cancer, or a group of siblings all developing type of cancer. So maybe a woman and both of her sisters have breast cancer. Usually with these familial cases, it can be a mix of what we call genes and an environment, or another term for that being multifactorial. So sometimes we might see these cancer diagnoses at later ages. Is it potentially something in the environment? Was that woman and her sisters all exposed to something in their environment that, they weren't aware of at that time, might have increased their risk for cancer? Or if it is linked to a gene, maybe it's one of those lower risk or moderate risk genes where we might see, again, a later age of diagnosis compared to higher risk genes like BRCA1 and 2, where breast cancer diagnoses might arise at younger ages, 30s, 40s. So that brings us to the hereditary piece of this pie, and that's about 5 to 10% of all cancers are hereditary. So most cancers are sporadic, 5 to 10% are hereditary. And by hereditary, we mean there's a mutation, a change, a spelling error that this person was born with that is increasing their risk, their lifetime risk for cancer. So that mutation was present either in the egg or the sperm cell that created that individual. So all that to say that all cancer, is genetic, but not all cancer is hereditary. So at the end of the day, there is a mutation involved when cancer arises, but it's the difference between whether the mutation was present at birth or whether the mutation arose at some point during this individual's life. And I think that this next slide kind of illustrates that, in a little bit more of a concrete way. So here, let's just, pretend this is this individual. These are two separate individuals. This first individual has hereditary, has a chance to develop hereditary cancer. So at birth, and these two blue rods are the chromosomes, or thinking back to the book analogy, the chapters. So these two chromosomes, they have one of their genes has a mutation in it. They were born already with one mutation. So over time, all they need is one sporadic or random mutation to lose, you know, that gene's ability to suppress tumors. And, you know, subsequently a tumor would develop. So all of these little blue circles are essentially cells kind of dividing out of control and clumping together. And that's essentially what a tumor is, just cells dividing out of control. They're not being kept in check. And that is a tumor. So in the hereditary cancer, you only need one sporadic or random mutation to be at that increased risk to develop a tumor. In this individual's case, they have developed sporadic cancer. So at birth, again, the blue rods being the chromosomes, at birth, they had no mutations. They were born, both of their genes, you know, were working. In this case, we're talking about breast cancer. So we can say, you know, their BRCA genes in this case were working. They had no mutations. Then at some point during their life, a sporadic mutation occurred. Then at some point later on in their life, they accumulated another mutation, and now they've lost that ability to suppress tumors, and a tumor develops. So, you know, for the hereditary cancer piece, you're kind of only one step away from that possible tumor development. In the sporadic cancer case, you have to acquire 2 mutations. So that's why when you're born with a mutation, you're already at that increased risk, because, you know, you need 1 more as opposed to 2. So that brings us to talking about BRCA1 and 2 a little bit more specifically, now that we've kind of laid a little bit of that background and talked about those differences between hereditary and sporadic cancer. So BRCA1 and 2, BR stands for breast and the CA stands for cancer. So it's an acronym essentially. And the 1 and the 2, I think, just relate to which one was found first and which one was found second. I like to tell patients that a lot of these gene names are kind of alphabet number soup. Some of the genes, you know, there are a series of letters and numbers, and not all of them necessarily stand for something. I think one of my favorite genes is SHH, which stands for Sonic Hedgehog. So just like the blue cartoon hedgehog that you might be picturing in your mind, I think they just named it that because whoever found it first was a big fan of Sonic the Hedgehog. So again, they don't all stand for something as kind of clear cut as BRCA does. So BRCA1 and 2 are tumor suppressor genes. So thinking back to that, you know, previous slide, their job in your body is to protect your body from developing tumors. So they're actually kind of doing the opposite. They don't cause cancer. They're trying to stop your body from developing cancer. It's when you have a mutation in them, a spelling error that impacts their function, that's when you develop cancer. So they're there to actually suppress tumors, not to cause them. And most importantly, women and men have these genes. So a lot of times, you know, patients come in and it's like, oh, you know, I want to find out if I have this gene. You already have them. You were born with them. You inherited 1 copy of the BRCA genes from your mom. You inherited another copy from your dad, and males as well. So they have BRCA1 and 2 genes. The question isn't whether you have the genes. The question is, do you have a mutation in the gene that is impacting the gene's ability, in this case, to suppress tumors? So genetic testing is helpful because genetic testing finds out whether this gene is working properly. It reads the recipe, it reads the instruction manual, it reads through that code. Looking for spelling errors or mistakes could be a deletion, could be a duplication, could be something swapped around. And if it shouldn't be there, that would be reported essentially as a positive or a pathogenic mutation. And subsequently kind of touched on this point already that when the genes aren't working properly, that's where that increased risk for cancer comes from. And then just in case you were curious, again, we have those 46 chromosomes, 23 pairs, and BRCA1 can be found on chromosome 17 and BRCA2 found on chromosome 13. So getting more into the numbers piece about with BRCA mutation. So all women, kind of regardless of their background, have a 12% risk for breast cancer. So we say population risk for breast cancer is 12%. But when we know that when we find women that have BRCA mutations, that risk for breast cancer over the lifetime can go up quite high. So up to over 80%, as we can see, here in this chart. So here at age 50, for someone who doesn't have a BRCA mutation, which would be general population in the blue, they're around that 2% at age 50. But for a woman that has a BRCA mutation, that risk is up to 51%. Similarly, by age 70, if you didn't have a BRCA mutation, general population, you were around 8%. With that BRCA mutation, up to and over 80%. BRCA 1 and 2 also have risks for ovarian cancer as well. And we can see risks for ovarian cancer up to and over 60% over the lifetime. So, if you've known someone either in your family or a friend or even just in the media, hearing about someone who's had a BRCA 1 or 2 mutation, and they say, well, I tested positive and I decided to remove my breast and or ovaries. These are kind of some of those numbers that led them to that decision, because we know those risks are much higher than that general population of 12%. And the main drive for that is, if you remove those organs, you would greatly reduce the risk of either developing a second breast cancer, if it's breast cancer, and then if you remove your ovaries, it can greatly reduce your risk for ovarian cancer. But just also another key bit of information, and this is usually the part that many patients come into the session not aware of, but BRCA mutations also carry increased risks for prostate cancer, some slight increased risk for pancreatic cancer and melanoma as well. And that's usually the part that patients find a little bit more surprising, because, and rightly so, BRCA stands for breast cancer, as we discussed. So it gets, associated very heavily with breast cancer, but there are risks for other types of cancer. Obviously, men don't have ovaries, so they're not going to develop ovarian cancer, but maybe in your family or a friend's family, it looks like having a father or an uncle with prostate cancer, or maybe someone in the family, a couple of people in the family with pancreatic cancer. So it doesn't always look like breast and ovarian cancer, and particularly in families that are male heavy, BRCA mutations can almost seem to hide a little bit. And it's not because they're not there, but the highest risk for cancer might be in organs that a man just, does not have. Or, the risk for male breast cancer with BRCA mutations is increased, but not nearly anywhere near 80% over the lifetime. So touching a little bit on management, so that kind of takes us from that conversation that we had on the last slide about, surgery options. There's many different kind of management options for people who test positive. for BRCA1 and 2, and how those can reduce those risks. So, with ovarian cancer, if you take a certain oral contraceptives, it can reduce the risk for ovarian cancer up to 60%. If you qualify or eligible to take tamoxifen, which is kind of a hormone blocker that sometimes women get prescribed when they have breast cancer, so that when their cancer is hormone fed, can reduce that risk for breast cancer up to 53%. Having a mastectomy can reduce the risk for breast cancer over 90%. And then an oophorectomy, which is removing the ovaries, can reduce the risk for ovarian cancer up to 96% and breast cancer up to 68%. So that's why typically the recommendation for BRCA positive women is to consider having a risk reducing mastectomy or to remove their ovaries prophylactically. Obviously, that may not be feasible for everyone, and every patient's going to make a different decision. Obviously, if the woman is younger, 20s, 30s, 40s, and she's still trying to, have children or thoughts about expanding her family, we wouldn't, go ahead and remove the ovaries. We would kind of wait till the childbearing years are done to have that surgery done, or if a woman wants to breastfeed, taking those things into consideration. So how does someone, inherit a BRCA mutation or any, gene mutation? There's a lot of different inheritance patterns. Autosomal dominant, which is displayed in this picture, is just one of them. There's several different patterns, but the way that BRCA1 and 2 are inherited, and as well as other genes known to increase the risk for breast cancer, they are typically inherited in this autosomal dominant pattern. So just for keeping with the theme, this check mark here is the working gene, so we can consider that a working BRCA gene, and the X would represent a non-working BRCA gene or a gene with a mutation. So in this scenario, mom's, both of her copies, she's got 2 check marks. Her BRCA genes are working. They are suppressing tumors and doing what they're supposed to do. In this scenario, the dad has the BRCA mutation. He has 1 check and he has 1 X. So one of his copies isn't working. So dad has a 50% chance of passing either on the working copy or the non-working copy. In scenarios of natural conception, there's no control over which copy gets passed down. So it's not like it's not a conscious choice that anyone makes. So 50% that some of his kids will get the check mark, 50% that some of the kids will get the X. So what we typically say when someone tests positive for BRCA1 and 2, or even another gene known to increase the risk for breast cancer, we say that there's a 50% chance that all first-degree relatives will also test positive. So that means children. That means that person's siblings and that person's parents. So, when these 2 kids here in the light blue shirt go on to have children of their own, they have 2 check marks. So they inherited, dad's working copy and mom's working copy. So when they have kids, all they can pass down are check marks. Their genes are working. That doesn't mean that, these 2 in the light blue couldn't develop breast cancer at some point in their life, because they can. We know that there's that 12% population risk. So even though they didn't inherit a mutation, they still have a population risk for breast cancer or other types of cancer. Now, for the kids in the darker blue shirt, they were born with that mutation. They have an increased risk to develop breast cancer or, any type of cancer, depending on the gene, over their lifetime. And subsequently, when they go to have children, they also have that 50-50 chance of passing down either a check mark working gene or an X, a non-working gene. So that's kind of how the pattern works and how it kind of, goes down through families. Again, testing positive or having a mutation doesn't guarantee that you will get cancer, just increases the risk. So now that we've kind of covered some of the cancer and genetics piece, we can kind of talk a little bit about what genetic counseling is and how it's helpful, and how someone like myself or any of my colleagues can help you, navigate the information we just talked about, and whether it's something that's right for you. So genetic counseling, I like to say, is just kind of an in-depth consultation or even conversation that helps patients make informed choices about genetic testing. So it's like a lengthy, consent process. If you've ever, signed up to participate in research of any kind, informed consent is a big part of research, making sure that patients understand, the objectives of the study, if there are any risks involved, what are they? If there are benefits, what are those? So that's essentially what a genetic counseling appointment is. It's an informed consent process about genetic testing. And during that conversation, we'll have education about cancer development, inheritance patterns, genetic testing, management and prevention. We can talk about, resources, whether that's, support groups or, resources about genetic information. So if you test positive, it's very typical for a genetic counselor to provide you with a family letter. And a family letter kind of breaks down a lot of the information we just went over in the previous slides in layman's terms, that you can share with your family. Because when you're coming into the appointment and there's a lot on your mind and we're going through a lot of different topics, it's hard to remember everything. And then especially once the test results come out, could be a couple of weeks from that conversation. So a family letter can be helpful to share with your loved ones, of saying, hey, I got testing, I tested positive. And then it will usually contain like contact information for how they can reach a genetic counselor in their area. And we also talk about insurance coverage and how that works with genetic testing, because obviously, there is a cost associated, and that can weigh a lot on patients' minds. We also collect family history, so going through and asking questions about who has had cancer in the family. If so, what type of cancer? How old were they? What was the outcome? If someone in the family, if your mom had breast cancer, did she have her breasts removed, or was it, did she have a lumpectomy and then the cancer never returned? Did she need chemo? All of these things are questions that can help us, provide a risk assessment and kind of see, what the severity of the cancer was. We're also here to provide psychosocial support. I think it goes without, saying cancer is difficult, to put it lightly. It's not always easy to have these conversations, especially when it's like a newly diagnosed patient. A lot of times they're going through a lot. It's, doctor's appointment after doctor's appointment. And this is just one more appointment. And most times, patients come in and they don't even know why they're here to see me or another genetic counselor. And so it's just kind of a long journey as they're working their way through to hopefully beating cancer. And sometimes even talking about the family history can make people emotional, especially if there's someone in the family that died suddenly of cancer, or maybe even had a long painful battle with cancer. That can bring up emotion. So we're there to talk through those things if a patient feels inclined to do so. And of course, we help facilitate testing. So what type of testing do you want? Are you interested in doing a blood sample or a saliva sample? Things like that. So is genetic testing right for you? So this kind of gets into testing criteria. There's this organization called the National Cancer Network, or NCCN. And they set forth these testing criteria to help guide like who would benefit from genetic testing. So these are just some of them, and I won't read through all of them, but key ones would be diagnosis of breast cancer before the age of 45. Remember, diagnoses under 50 and under is considered young for breast cancer. A male relative with breast cancer, that's definitely more rare. Men can develop breast cancer, but it doesn't happen as often. So that can be maybe a trigger that there could be something hereditary going on. If you're of Ashkenazi Jewish ancestry, we know that that 1 in 40 people who are Ashkenazi Jewish are carry BRCA mutations. And that's just because that population kind of started off from a very small group of people that were, having children with, their relatives, and that can, cause mutations to pop up and then get passed down through generations. And then if you've had a history of any of these cancers, and or have a history of any of this criteria, and you've tested negative for BRCA 1 and 2 in the past, if you've had BRCA 1 and 2 testing, even 5+ years ago, updated testing is available. Testing technology has grown exponentially since then. So sometimes when patients are like, oh, I had BRCA 1 and 2 tested in 2009, a lot has changed in testing since 2009. So it's definitely, valid and worth taking a look into those genes again with updated technology. And this was just a little bit of a reminder of myself so that I don't forget to mention it. But if you have been tested, in the past, and you have those reports, or someone in your family has been tested and you have those reports, bring them with you. If you're coming in person, bring those genetic test reports with you. Or if you're having a phone appointment or a video appointment, have it at the ready to maybe send through email. It really helps us build that risk assessment. And then we can talk through the results with you. I like talking through previous results with patients so that they get a full understanding of what's going on. Sometimes patients are like, oh, I think my, sister or my aunt tested positive for BRCA 1, but then when we get the report, it's not BRCA 1, it's BARD1, BARD1, which does increase the risk for breast cancer, but not nearly the same amount as BRCA. So that's an important distinction. And I wouldn't want to miscounsel somebody thinking, it was BRCA, maybe because the patient can remember. So if you can get those reports, or if you're coming to see a genetic counselor, reach out to your family, get them to send the reports and bring them on in. This slide is just talking about, other indications. Again, this is, Breast Cancer Awareness Month, so we're focusing on that. But there are, other cancer if you have family history of these cancers, consider genetic testing, especially if it fits within the criteria on that last slide. Anyone in the family with these kinds of cancers under the age of 45, multiple first and second degree relatives with any of these types of cancers, genetic testing could be considered. Okay. So beyond BRCA 1 and 2, we now know that there are, multiple genes that can increase the risk for breast cancer. There was a U.S. Supreme Court case back in 2013. So the Supreme Court versus a particular lab that kind of wanted to corner the market on BRCA1 and 2 testing, and the Supreme Court essentially said you can't do that. You can't patent genes. You might have, discovered them, or you might have isolated them, but you didn't create them, so you don't own them. And then essentially, once that ruling happened, there was like an explosion in genetic testing, and panel testing started to just pop up everywhere. All labs kind of just went for it. The floodgates kind of opened up. So here in this chart on the left, these are other genes, including BRCA1 and 2, that can increase the risk for breast cancer. But as you can see, some of the genes also have risk for other things in italics. Take, CDH1. So this gene here, for example, increase the risks for lobular breast cancer, but also a specific type of gastric, cancer. So even when we're doing panel testing, and we just look at, these 9 genes here, and this would be an example of what we call a stat panel, because these risks for these genes are higher, or breast cancer risks are higher. You're still going to learn information about other types of cancer beyond just breast. Breast is what they all have in common, but they have other cancer risks as well. So this is just kind of taking, opening the door and looking beyond, BRCA1 and 2. So moving forward with additional testing. So like I said, testing has exploded. It's grown exponentially. Now testing is typically done on multi-gene panels. Again, we have these stat breast panels, 8 to 9 genes, very similar to what I showed on that last slide. And that's usually available for patients who have pending surgery or treatment decisions. So if a woman is considering, lumpectomy versus mastectomy, testing positive on one of those 8 or 9 genes can maybe sway her more towards having a mastectomy, versus testing negative might sway her more towards a lumpectomy with radiation. Those stat panels also tend to have shorter turnaround times. That's what TAT stands for. So anywhere between 5 to 12 days. Trying again, just with the understanding of trying to get these results quicker, because we know surgery is pending. There are now, the larger cancer panels that we have now are up to 80 plus genes. Not all of these genes relate to breast cancer. Some of them, relate to other types of cancer, colon cancer, thyroid cancer, soft tissue tumors. But, the amount of information you can gain is now, way more than just BRCA1 and 2. And then many labs offer patients a self-pay option, maximum of $250. And this is just to help create access to testing, because, each insurance company has their own kind of criteria. Some are a little bit more picky than others. And, the labs want to make sure that people can get access to testing, and they also provide financial assistance. So sometimes patients may even pay nothing. And most patients do end up paying nothing, because the lab's billing department reaches out to the patient's insurance company and really tries to work, to get it covered as much as possible. And typically turnaround time as of today is usually between 2 to 3 weeks from the time that the lab receives the patient's sample. So I always like to say, the longer you hold on to your kit, especially if you mail it to your home, the longer you have your testing kit is the longer the lab doesn't. So keep that in mind when you're doing, genetic testing. You can kind of delay getting the results back. So once we get the testing, there's different results, 3 different results we can get. A negative result, which means we looked into that code, we read that recipe, and we didn't find any errors. There's the positive result, which we've talked about, and possible implications, whether that be surgery or whether that be increased screening. There's also a third possible result called a VUS, or a variant of uncertain significance. And that's just the lab's fancy way of saying they don't really know what this change is. They found it. They don't know if it's harmful. They don't know if it's benign. Their evidence is conflicting, so they call it uncertain. And this can happen on any panel. It can happen in any gene. I've seen uncertain results in BRCA genes. Sometimes those are a little bit more challenging, just because we know those genes have those high increased risks. And usually when we have uncertain results, we don't make recommendations based off of uncertainty, because we wouldn't want someone to have an irreversible surgery, and then over time, the lab gathers more data and says, never mind, this is a benign change. It's not harmful. And then someone has already chosen to remove their breasts or their ovaries at that point. So we wouldn't want that to happen. Something new that's kind of coming into the testing world is RNA analysis. And RNA is similar to DNA, chemically. It's just a little bit different, but it essentially allows for a little bit of a deeper analysis. And many of the labs tout it as a way to clarify uncertain findings. If you do, regular DNA testing, and then you add in that RNA piece, if there are any of those VUSs or uncertain findings, that RNA can kind of help clarify that. Not in every case. Right now, it's anywhere between 1 to 6% chance that it might clarify the findings. So it's not a large number, but this is something new that many of the labs are excited about. These are just some screenshots from some of the labs. So this bottom one here, this is just like some of the testing options for just breast cancer from one lab. So we can see there's like kind of 5 different panel options, and that's just for breast. That's not even touching other types of cancer. As you can see down here at the bottom, single syndrome testing options. So we still have just, the regular tried and true BRCA 1 and 2 testing. You can just test for those. But you can test for, even up to 36 genes that will give you information about breast, ovarian, colorectal, and uterine cancers. And then this other screenshot here is just the genetic testing offered, the vast variety from a different lab. So I circled hereditary cancer because that's the area where I live. But this lab offers testing for genetic conditions that cause cardiac issues and nephrology and neurology. So again, there's a lot of information that a patient can seek. And then this little picture down here is just kind of what a blood kit looks like. So if you come in and have your blood drawn, that's where the tubes are inside there. Or if you get it mailed to your house, that's kind of what shows up at your door. So I thought a way to kind of wrap things up with this talk, and this talk has been given in the past, and I saw that the previous person had some of these misconceptions slide, and I thought I really like that because, to be honest, these are statements that I hear, maybe if not, once a week or every other, week, that people kind of have about genetic testing or cancer, having the breast cancer only on the father's side and having nothing to worry about. We know that's not true. We know that men have BRCA genes. We know that they are at an increased risk for male breast cancer, not as much as women are. But we also know that they're at an increased risk for prostate cancer. So BRCA1 and 2 can have impacts on the males in the family as well. You know, I'm done with my cancer treatment, so I don't need genetic testing, or it's not relevant for me. If you test positive, you can be at an increased risk for a second breast cancer, or you can be at an increased risk for cancer in another organ. This is kind of why we're looking, you know, into it. You know, maybe, yes, you're done with your cancer treatment and that chapter is closed, but if your cancer was due to a hereditary cause, then we have to, you know, make sure you're not at risk for something else. These genes do not skip generations. Everyone is inheriting BRCA1 and 2 among all of the other 20,000 genes that humans have. Everyone's inheriting them. It's not a matter of whether you have the gene, it's whether you have a mutation. I've had oncotype, KRAS, or Foundation 1 testing. These are tumor testings, and I had a slide on it, but you know, in the interest of time, I wanted to make sure we had time for questions at the end. But these are our tumor testing, and tumor testing essentially is testing done on the cells in the tumor only. So those mutations will only be present in the tumor. Hereditary mutations are going to be mutations that was present again in that egg or that sperm cell that that person was created from. So that mutation will be in all of their cells. Tumor testing is just looking at mutations in the tumor. They're not the same. And then I did 23andMe, and I already tested negative for BRCA. 23andMe is ancestry testing. Ancestry testing is something a little bit different. We're talking about hereditary cancer risks. Some of the 23andMe do include, you know, testing for BRCA, but a lot of the mutations they look for on 23andMe, at least last that I heard specifically, are those Ashkenazi Jewish, you know, founder mutations. So it's not looking for all types of BRCA mutations. It's just looking for the mutations we know are seen in Ashkenazi Jewish people, or people who have Ashkenazi Jewish ancestry. So if you're not Ashkenazi Jewish and you tested negative for the BRCA testing that they have in 23andMe, you could still have a mutation, and the 23andMe testing would have missed that essentially. So some of those health information testing on, you know, ancestry companies like 23andMe, it's not complete or comprehensive. Doesn't mean that it's not worth adding it in if you're curious about that information, but just be cautious and know that it's not as, you know, comprehensive as some of the testing that I showed on the previous slides. And this is the contact information. So this is the team. These are all of the other genetic counselors, including myself, that are here at Northside. We also have two schedulers, Daphne and Sienna. We have a medical assistant, Denise, and our genetic counseling assistant, Emily, and we're all, you know, a part of this team, and we all work together to provide care for the patients. And this is how, you know, you can reach us at this number and this email. If you want to be seen by our hereditary cancer program, you'll need a referral from your provider. And once you have that, we will reach out and schedule an appointment for you. And that's the end of it. I think we have about 10 more minutes, so hopefully that will be enough time to get everyone's questions answered. And I will go back to this slide on the contact information in case anyone wanted to jot that down.
Thank you so much, Jasmine. We did have quite a few questions submitted, so I'll try to get to all of them. First one, because my breast cancer was due to an ATM gene, can you talk about that, the single variant, not the double variant?
Okay. Yeah, so ATM is a gene that does increase the risk for breast cancer. I think it falls what I would say in a moderate risk. So I believe, around 40-ish% over the lifetime. So yes, more than likely you only had one mutation. So you only need one mutation to be at an increased risk. If you had two ATM mutations, that is a completely different syndrome. It is more severe, and you would have known that you had that probably from birth. That's usually how a lot of those genes work. If you have two mutations in the same gene, it's usually a little bit more rough. So yeah, ATMs is a moderate risk breast cancer gene. Sometimes we might see ages of diagnosis a little bit later. So those family patterns may not always look, like a typical kind of BRCA 1 and 2 pattern, but that's why panel testing is helpful, because if we only looked at BRCA 1 and 2, we would miss those ATM patients. But I've counseled on ATM before. You do have that option of whether you want to have a risk reducing mastectomy, but also sometimes it's just recommended to increase your breast screening. So either MRIs or mammograms, which is standard, and adding MRIs and such. Hopefully that answers the question.
I was tested at Northside Genetics in November of 2019. Is it true that another gene has been discovered beyond BRCA1 and 2 since that time?
Well, if you had testing in 2019, I don't know if you only had BRCA 1 and 2 looked at, but if you had a panel, it would have included, any breast-focused testing panel would have included those genes, BRCA 1 and 2, ATM, CHEK2, PALB2, which a patient told me was, I think, in the news recently. It would have looked at those. That's about 2 or so years ago, which is fairly recent. So I would say if you had kind of, concerns about updates, you can reach out and, just schedule maybe a brief call to see if anything has changed, or if we think updated testing would be necessary. I have phone calls like that from time to time. It's not a full-blown appointment, just a brief chat about whether the patient should be tested again. But 2019 is not too long ago, so.
Okay, we had another question about getting retested. So like she said, contacting a genetic counselor to talk about your specific diagnosis probably would be the best bet there. A 61-year-old woman's mother who is 80 has been diagnosed with triple-negative breast cancer. Should a 61-year-old be tested? And wondering about insurance covering cost.
Right. So, there is testing criteria. A lot of times that, leans more on age of diagnosis and family history, but there are some things where it doesn't matter what age you are. If it applies to you, then you fit criteria for testing. Triple negative is one of those. So if you have triple negative breast cancer at any age, that is also one of those kind of automatic qualifications for looking into hereditary cancer testing. It would be best if the testing is done in that patient's mom. So we always say genetic testing, particularly in this setting, is always the most informative when done in the patient that has cancer. If we test somebody that doesn't have cancer, it's not that information isn't important or useful, but do you not have cancer because you didn't inherit a mutation? Is a mutation there and you just didn't inherit it? Remember, there's that 50-50 split. Mm-hmm. Essentially, we can't say whether you're a true negative unless we kind of test that person with cancer. So it'd be best to start with her mom if she's available or willing.
Mm-hmm. If a person receives genetic testing and shows a high percentage for cancer in the future, what are the consequences of knowing this information? As, for example, insurance increases?
Right. So there is protection against, insurance discrimination. There's something called the Genetic Information Non-Discrimination Act, or GINA for short, and it was started in 2008, and it protects patients from insurance discrimination. So particularly health insurance. So if someone, tests positive for a high, risk gene, and it stops their insurance company from kind of like changing their policy or raising their premiums on them. If you have a life insurance policy already and then you test positive, your life insurance policy is fine. If you test positive and then you try to go and get a new life insurance policy, that's where things might get a little bit hairy, because with life insurance, they kind of look into the medical record and all of that. So sometimes we would advise patients to, if you're going to make changes to life insurance, maybe get that situated first and then do your genetic testing. GINA does not protect, unfortunately, against like long-term disability insurance or military insurance. And for some odd reason, if you work at a company with less than 15 employees, it doesn't cover you. I don't know why. I don't really have a reason for that. It's just an odd thing.
Was that 15 or 50?
Less than 15.
Less than 15. Okay. Well, good things to consider. Does Medicare cover genetic testing?
Yes. So there is a particular lab in Vitae. I think there was a little picture of their kit on one of those slides. They have kind of a, I don't know if the right word is deal or a contract. Essentially, like Medicare patients get testing for free. So if you have Medicare, it's going to be free, whether you just looked at BRCA1 and 2 or whether you looked at 84 genes, no cost.
All right. If a person was adopted and has no knowledge of their family history, would you recommend that they get tested? And do you think their insurance would cover it? So,
yeah, if you're adopted, you can definitely still, have genetic testing. It does limit in like the risk assessment in terms of like the family history. But I've seen patients that are like, oh, I was adopted, or like my mom was adopted, so we don't know anything about her side. We work with what we have, essentially. Sometimes patients aren't, and they just don't really know a lot about their family, or they're not close with their family. In terms of insurance coverage, I think it would play more on, does that patient have cancer? What's their age of diagnosis? What's the type of cancer? If they themselves meet criteria by themselves, then, I would expect insurance to cover it. If they don't, and they're just kind of curious about cancer risks, they may end up paying that self-pay option. But again, it's a maximum of $250. As long as you're comfortable with that price, the testing is open and available to you.
How does a patient avoid a huge medical charge when doing panel testing? Some insurance does not allow for panel testing, but rather only approve specific testing. Do you have any tips on how to discuss this with your provider?
I guess for like, those insurance, sometimes insurance have like pre-auth forms, nothing a patient has to fill out. But I've filled out a couple of them, and they might only approve, certain things. Usually insurance is kind of all or none. They're going to cover it completely, no matter the panel, or they don't. And if they don't, and you want more testing, and they, quote kind of a ridiculous number back, that's usually when the lab will kind of trigger that self-pay and have that discussion with you. Because the labs, they try their best, but there's only like kind of so much they can do on the insurance piece. But if you want more information, you should be entitled to get that, even if your insurance company is trying to limit you. And I always have this conversation with patients, just kind of letting them know, like, and the lab will communicate that to you. The lab gets your information, and they will reach out to you and say your insurance company is only going to approve this, but if you want this additional testing, consider self-pay.
How about the genetic counseling session itself? Is that typically covered?
So here we don't charge for our counseling sessions. Maybe at some places they do, but from what I've been informed here, there isn't a cost for this genetic counseling service.
All right, we are at right past 1 o'clock actually, so I do want to be mindful of your time, Jasmine. I know that you still have to work today and have patients to see. So we have had some people ask about whether or not we'll be sharing the slides. This session was recorded today, and we will be posting that on our website, cscatlanta.org, in the coming weeks once we have it downloaded and edited. So that will be available to you. Jasmine, if you want to share your slides, I'm happy to send those out as well. Any closing thoughts? We're getting a lot of comments about how valuable this presentation was. A lot of thank yous, great presentation. Thank you so much. So a lot of great feedback. Any closing thoughts from you?
You know, like if you do get an appointment, have questions, we're here to answer the questions. This is you know, complicated information. Some of it people might recall from like school, or maybe if they particularly had an interest in genetics, but we don't expect you to come into the appointment having a in-depth knowledge of all of this information. That's what we're here for. And even after the appointment, we can be a resource. Sometimes I'll email patients, you know, links to websites that I know are reputable and have correct information if they're looking for more information. So, you know, we're here to be a resource. There are no silly or ridiculous questions if you have them. So, you know, feel free to reach out.
All right, thank you so much. Thank you everyone for joining us today and for submitting all the questions. I'm sure that other people benefited from seeing your questions as well, so we appreciate you asking those. Thank you, Jasmine, for taking the time to do this presentation. It was wonderful. So many people are talking about how much they enjoyed it in the chat box. But everybody else, just have a wonderful Friday. Have a great weekend. And thank you for joining us.
Thank you, everyone. Appreciated being here.
All right, everyone. Take care. Bye-bye.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.